I think the most interesting one was the one on wearable technologies and the ability that these technologies could actually provide good ground for care in Parkinson's disease. I think that we have a lot of instruments, a lot of tools to monitor gait and balance. Many of us are wearing watches that can record biological measures like the heart rate and the breath and the saturation of the blood, oxygen saturation in the blood. I think we don't have yet a very comprehensive way to introduce this in the clinic, but I believe that in the future we will be able to provide, monitoring, telemonitoring, rather than simple visits. One of the issues in Parkinson is that you schedule a visit, the person comes, and after the visit, the person lives, and the next appointment may be 3-6 months or 1 year later. What happens to these people during this 6 months, 1 year? We get to know little, maybe by email, WhatsApp, and other contacts, but we don't have a systematic way to monitor, like in cardiology we would do, for instance, monitoring. The other debate I was involved in was on, advanced therapies and the opportunity to use specific criteria to select patients. I think, that there is a need to get a more uniform assessment of Parkinson patients. There is too much heterogeneity among the doctors who evaluate these patients, not only among different countries, but also within one country. So there are not very strict inclusion criteria. They are quite flexible. I was involved in an effort to introduce a concept of which could be simply communicated of 5-to-1, so 5 doses of levodopa, 2 hours of off with impact on functionality, and maybe if it's there, 1 hour of dyskinesias with functional impact. Now, I think having a criteria of this kind, so if you have increased the dose of levodopa up to 5 times a day, if your patient has still 2 hours of off time with disability and maybe with or without dyskinesias, I think this patient deserves maybe either an additional medication adjustment, but it is a good time to start discussing about device-aided therapies. And we have not only now the infusions, we have deep brain stimulation, we have focused ultrasound, and we will have soon next year, I hope, a subcutaneous levodopa infusion, which is also seems to be quite a promising strategy to deliver continuously levodopa to our patients.